Are you ready to conquer the Nclex with confidence? In this video, we're diving into high-yield GI gastrointestinal questions that every nursing student needs to know before exam day. We'll tackle common pitfalls, share proven test-taking strategies, and break down complex concepts into easy-to-remember tips. Whether you're aiming for a first-time pass or simply brushing up your knowledge, these GI Nclex questions are designed to sharpen your critical thinking and reinforce essential nursing skills. Stick around to learn insider tricks that will help you spot the best answers on the test. And don't forget to take notes. By the end of this video, you'll feel more prepared, more confident, and one step closer to celebrating your Nclex success. Let's jump right in. 1. Question. A 48-year-old female presents with right upper quadrant pain, fever, and jaundice. She reports a recent history of fatty meal intolerance. Her vital signs reveal a temperature of 101.5 degrees Fahrenheit and tachycardia. Which intervention should the nurse prioritize? Answer options. A. Administering oral antibiotics and scheduling an outpatient ultrasound. B. Encouraging increased fluid intake to flush the biliary system. C. Preparing the patient for immediate surgical consultation. D. Teaching the patient about a low-fat diet for symptom management. Correct answer. C. Preparing the patient for immediate surgical consultation. Rationales for each answer. Option. Rationale A. Administering oral antibiotics. Incorrect. While antibiotics may be part of the treatment for ascending cholangitis, the priority is surgical evaluation to relieve biliary obstruction and prevent sepsis. Rationale B. Encouraging increased fluid intake. Incorrect. While hydration is essential, it does not address the obstruction causing the patient's symptoms. Rationale C. Preparing for surgical consultation. Correct. The patient exhibits symptoms of acute cholangitis, Charcot's triad, a medical emergency requiring prompt biliary decompression and surgical intervention. Rationale D. Teaching about a low-fat diet. Incorrect. Dietary changes may help in chronic gallbladder disease, but are not a priority in acute cholangitis. Mnemonic. Triad for cholangitis symptoms: temperature, fever, right upper quadrant pain, icterus, jaundice, address obstruction, surgery, drainage or decompression, central topic explanation and comparison. Acute cholangitis. This condition results from bacterial infection superimposed on biliary obstruction, often caused by gallstones. Key features include Charcot's triad, fever, right upper quadrant pain, and jaundice. Management requires immediate antibiotics, biliary decompression, ERCP, and potentially surgery. Key interventions. Administer broad-spectrum antibiotics to address infection. Hydrate with IV fluids to stabilize the patient. Prepare for urgent biliary decompression, ERCP or surgery. Comparison with cholecystitis. Pathophysiology. Cholecystitis involves inflammation of the gallbladder, typically due to gallstone obstruction, without infection spreading to the bile ducts. Symptoms. Both conditions present with right upper quadrant pain, but jaundice is more typical of cholangitis. Fever may occur in both, but tends to be higher in cholangitis due to systemic infection. Management. Cholecystitis often resolves with antibiotics and eventual cholecystectomy, whereas cholangitis requires urgent biliary decompression to prevent sepsis. 2. Question. A 36-year-old patient presents with epigastric pain that worsens with eating. He reports frequent NSAID use for chronic knee pain. An endoscopy reveals a gastric ulcer. What is the nurse's priority intervention? Answer options. A. Instructing the patient to avoid spicy foods and caffeine. B. Administering proton pump inhibitors as prescribed. C. Encouraging the use of over-the-counter antacids for pain relief. D. Scheduling a follow-up endoscopy in 6 months. Suru. Correct answer. B. Administering proton pump inhibitors as prescribed. Rationales for each answer option. Rationale A. Avoiding spicy foods. Incorrect. Dietary modifications can help reduce irritation, but do not address the underlying pathophysiology of gastric ulcers. Rationale B. Administering proton pump inhibitors. Correct. PPIs are first-line therapy for reducing gastric acid secretion and promoting ulcer healing, especially in NSAID-induced ulcers. Rationale C. Using antacids. Incorrect. Antacids provide temporary relief, but do not treat the underlying cause of the ulcer. Rationale D. Scheduling follow-up endoscopy. Incorrect. This may be necessary later, but the priority is initiating treatment to reduce acid secretion and promote healing. Mnemonic. Gastric for gastric ulcer management. Give PPIs, avoid NSAIDs, stop smoking, teach dietary modifications, reduce stress, initiate H. pylori treatment, if applicable. Check for complications, bleeding, perforation. Central topic explanation and comparison. Gastric ulcers, caused by NSAIDs, H. pylori or other factors that compromise mucosal defenses. Symptoms include epigastric pain, worsened by eating. Treatment involves acid suppression, PPIs, and addressing the underlying cause. Key interventions: discontinue NSAIDs to prevent further mucosal injury. Administer proton pump inhibitors to reduce acid secretion. Test for and treat H. pylori if present. Comparison with duodenal ulcers. Pain patterns. Gastric ulcers cause pain exacerbated by food, while duodenal ulcers cause pain relieved by eating but worsen hours later. Etiology. Both may be associated with H. pylori, but NSAID use is more common in gastric ulcers. Treatment. Both respond to acid suppression therapy, but duodenal ulcers often heal faster with treatment. 3. Question. A 25-year-old patient presents with bloody diarrhea, abdominal pain, and weight loss over the past month. Colonoscopy reveals continuous inflammation starting at the rectum and extending proximally. What is the nurse's priority action? Answer options. A. Administering antibiotics for suspected infection. B. Educating the patient on corticosteroid use. C. Initiating total parenteral nutrition, TPN. D. Preparing the patient for emergency surgery. Correct answer. B. Educating the patient on corticosteroid use. Rationales for each answer option. Rationale A. Administering antibiotics. Incorrect. Ulcerative colitis is an inflammatory condition, not primarily infectious, so antibiotics are not the first-line treatment. Rationale B. Educating on corticosteroid use. Correct. Corticosteroids reduce inflammation and are used in moderate to severe ulcerative colitis to induce ISA. Rationale C. Initiating TPN. Incorrect. Nutritional support may be needed in severe cases, but is not the immediate priority. Rationale D. Preparing for surgery. Incorrect. Surgery is reserved for complications or refractory disease, not as an initial intervention. Mnemonic. UC care for ulcerative colitis. Management. Understand corticosteroids. Consider immunosuppressants. Correct electrolyte imbalances. Add aminosalicylates. Regulate diet, low residue. Educate about flare triggers. Central topic, explanation and comparison. Ulcerative colitis, UC, a chronic inflammatory bowel disease affecting the colon and rectum, characterized by continuous inflammation and bloody diarrhea. Management focuses on reducing inflammation, corticosteroids, aminosalicylates, and preventing complications. Key interventions. Administer corticosteroids to induce remission. Use aminosalicylates for long-term maintenance therapy. Monitor for complications like toxic megacolon or colon cancer. Comparison with Crohn's disease. Location. UC affects only the colon and rectum, while Crohn's can involve the entire GI tract from mouth to anus. Pattern of inflammation. UC is continuous from the rectum proximally, whereas Crohn's involves patchy skip lesions. Complications. UC increases the risk of colorectal cancer, while Crohn's is more associated with fistulas, strictures, and malabsorption. Surgical intervention. Surgery is curative for UC, colectomy, but not for Crohn's, where recurrence is common after resection. 4. Question. A 62-year-old male with a history of alcoholism presents with abdominal distension, jaundice, and confusion. His laboratory results show elevated ammonia levels and low albumin. What nursing intervention is most appropriate? Answer. Options. A. Administering lactulose to reduce ammonia levels. B. Restricting fluids to manage ascites. C. Providing a high-protein diet to promote healing. D. Administering vitamin K to correct coagulopathy. Correct answer. A. Administering lactulose to reduce ammonia levels. Rationales for each answer. Option. Rationale A. Administering lactulose. Correct. Lactulose reduces serum ammonia levels by trapping ammonia in the colon and promoting excretion, addressing hepatic encephalopathy. Rationale B. Restricting fluids. Incorrect. Fluid restriction may be necessary for hyponatremia, but does not address the primary concern of encephalopathy. Rationale C. Providing a high-protein diet. Incorrect. High protein can worsen encephalopathy by increasing ammonia production. Rationale D. Administering vitamin K. Incorrect. Vitamin K may help with coagulopathy, but does not address the immediate issue of hepatic encephalopathy. Mnemonic. Help for hepatic encephalopathy. High ammonia treated with lactulose. Encourage monitoring mental status. Limit protein intake, if severe. Prevent precipitating factors. Infection, GI, bleed. Central topic, explanation and comparison. Hepatic encephalopathy, a complication of liver disease caused by elevated ammonia levels due to impaired detoxification. Symptoms include confusion, asterixis, and coma. Lactulose is the first-line treatment. Key interventions: administer lactulose to reduce ammonia levels. Identify and treat precipitating factors, e.g. infection, GI bleeding. Monitor mental status and ensure patient safety. Comparison with ascites. Cause. Ascites results from portal hypertension causing fluid leakage into the peritoneal cavity, while hepatic encephalopathy arises from ammonia buildup affecting the brain. Symptoms. Ascites presents with abdominal distension and shifting dullness, while hepatic encephalopathy involves confusion and neurological deficits. Management. Ascites is treated with diuretics and paracentesis, whereas encephalopathy requires lactulose and precipitant management. Prognosis. Both conditions signify advanced liver disease, but encephalopathy is more immediately life-threatening without intervention. 5. Question. STEM. A 67-year-old male with a history of chronic constipation presents with left lower quadrant pain, fever, and a palpable mass in the abdomen. What is the nurse's priority intervention? Answer. Options. A. Preparing the patient for barium enema imaging. B. Administering clear liquids and observing for improvement. C. Initiating intravenous antibiotics as prescribed. D. Encouraging high-fiber foods to relieve constipation. Correct answer. C. Initiating intravenous antibiotics as prescribed. Rationales for each answer option. Rationale A. Barium enema imaging, incorrect. This is contraindicated during acute diverticulitis due to the risk of perforation. Rationale B. Clear liquids and observation, incorrect. While dietary modifications are part of long-term management, antibiotics are necessary during acute inflammation. Rationale C. For antibiotics, correct. Diverticulitis often involves bacterial infection, requiring prompt antibiotic therapy to prevent complications like abscesses or perforation. Rationale D. High-fiber foods, incorrect. Fiber is beneficial during remission, but contraindicated in acute diverticulitis due to risk of worsening inflammation. Mnemonic. Divert for diverticulitis management. Diet. Low residue during flares. Initiate antibiotics. Vitals monitoring. Evaluate for complications. Rest the bowel. NPO if severe. Transition to high fiber post-recovery. Central topic explanation and comparison. Diverticulitis. Inflammation or infection of diverticula, often in the sigmoid colon, presenting with left lower quadrant pain, fever, and leukocytosis. Management focuses on bowel rest, antibiotics, and preventing complications. Key interventions. Administer IV antibiotics to treat infection. Provide bowel rest with a clear, liquid diet. Monitor for signs of perforation or abscess formation. Comparison with diverticulosis. Diverticulosis. Presence of diverticula without inflammation, typically asymptomatic. Diverticulitis. Involves infection and inflammation, often requiring antibiotics and dietary modifications. Management. Diverticulosis is managed with a high-fiber diet, whereas diverticulitis requires bowel rest and antibiotics. 6. Question. STEM. A patient with gastroesophageal reflux disease, GERD, reports persistent heartburn despite taking over-the-counter antacids. They mention that symptoms worsen at night. Which nursing education point is most important to share? Answer options. A. Avoid drinking water during meals. B. Elevate the head of the bed while sleeping. C. Avoid eating spicy foods entirely. D. Schedule a follow-up with a gastroenterologist. Correct answer. B. Elevate the head of the bed while sleeping. Rationales for each answer. Option. Rationale A. Avoiding water during meals. Incorrect. Drinking water during meals does not significantly impact GERD symptoms and is not evidence-based advice. Rationale B. Elevate the head of the bed. Correct. This reduces the likelihood of gastric contents refluxing into the esophagus, particularly during sleep. Rationale C. Avoiding spicy foods. Incorrect. While avoiding triggers can help, it is not the most effective intervention for nighttime symptoms. Rationale D. Scheduling a follow-up. Important, but not correct. A follow-up may be needed, but initial lifestyle modifications should be prioritized. Mnemonic. Sleep for GERD relief. Sleep with the head elevated. Limit large meals before bed. Eat smaller portions. Exclude alcohol and caffeine. Prevent triggers. Central topic. Explanation and comparison. Gastroesophageal reflux disease. GRD. GERD occurs when stomach acid frequently flows back into the esophagus, causing symptoms such as heartburn and regurgitation. Chronic GERD can lead to complications like esophagitis or Barrett's esophagus. Key interventions. Elevate the head of the bed to reduce nighttime symptoms. Avoid triggers like fatty, spicy foods and caffeine. Consider medical evaluation for refractory cases. Comparison with peptic ulcer disease, PUD. Symptoms. GERD causes regurgitation and burning in the chest, whereas PUD presents as localized pain. Management. GERD focuses on lifestyle and acid suppression, while PUD often involves treating H. pylori or avoiding NSAIDs. 7. Question. STEM. A patient undergoing treatment for Crohn's disease reports persistent fatigue and pallor. Laboratory results reveal a hemoglobin level of 8.0 gdl and microcytic anemia. What is the most likely cause of this finding? Answer. Options. A. Iron deficiency anemia due to chronic intestinal bleeding. B. Vitamin B12 deficiency due to ileal malabsorption. C. Anemia of chronic disease due to systemic inflammation. D. Folate deficiency due to poor dietary intake. Sature. Correct answer. A. Iron deficiency anemia due to chronic intestinal bleeding. Rationales for each answer. Option. Rationale A. Iron deficiency anemia, correct. Microcytic anemia is most commonly caused by chronic blood loss, which is a frequent complication of Crohn's disease. Rationale B. Vitamin B12 deficiency, incorrect. B12 deficiency causes macrocytic anemia and is more likely in patients with severe ileal involvement. Rationale C. Anemia of chronic disease, incorrect. Anemia of chronic disease is usually normocytic and occurs due to inflammation, but does not explain microcytosis. Rationale D. Folate deficiency, incorrect. Folate deficiency causes macrocytic anemia and is less common compared to iron deficiency in Crohn's disease. Mnemonic. Iron for Crohn's anemia. Identify blood loss. Replenish iron stores. Observe for malabsorption. Nutritional supplementation. Central topic explanation and comparison. Crohn's disease and anemia. Chronic blood loss from ulcers or inflammation in Crohn's disease can result in iron deficiency anemia. Symptoms include fatigue, pallor, and reduced exercise tolerance. Key interventions: replenish iron through oral or IV supplementation. Monitor for other deficiencies, B12, folate, common in Crohn's disease. Control intestinal inflammation to prevent ongoing blood loss. Comparison with ulcerative colitis, UC. Bleeding. Crohn's disease often causes occult bleeding, whereas UC leads to more visible rectal bleeding. Anemia types. Both can result in anemia, but iron deficiency is more common in Crohn's disease due to malabsorption and chronic blood loss. 8. Question. A patient presents with a sudden onset of bright red rectal bleeding during defecation but denies abdominal pain or changes in bowel habits. What is the most likely cause? Answer. Options. A. Hemorrhoids. B. Colorectal cancer. C. Diverticulosis. D. Anal fissure. Correct answer. A. Hemorrhoids. Breasts. Rationales for each answer. Option. Rationale A. Hemorrhoids. Correct. Painless rectal bleeding during defecation is a hallmark of hemorrhoids, which are swollen veins in the rectal area. Rationale B. Colorectal cancer. Incorrect. Rectal bleeding can occur with colorectal cancer, but it is typically accompanied by changes in bowel habits or systemic symptoms like weight loss. Rationale C. Diverticulosis. Incorrect. Diverticular bleeding is typically painless, but is often associated with larger volumes of blood than hemorrhoidal bleeding. Rationale D. Anal fissure. Incorrect. Anal fissures cause rectal bleeding, but are usually painful, especially during defecation. Mnemonic. Hem for hemorrhoidal bleeding. High fiber diet to prevent straining. External versus internal classification. Monitor for chronic bleeding complications. Central topic explanation and comparison. Hemorrhoids. Swollen veins in the rectum or anus that can cause painless bleeding during defecation. Commonly associated with straining during bowel movements. Key interventions. Increase dietary fiber to reduce straining. Use topical treatments to manage symptoms. Consider surgical interventions for severe cases. Comparison with anal fissures. Symptoms. Hemorrhoids are painless, while anal fissures cause sharp pain. Management. Fissures may require topical nitroglycerin, while hemorrhoids respond to dietary changes and procedural interventions. 9. Question. Which nursing intervention is most appropriate for a patient with a complete bowel obstruction presenting with severe abdominal distension and vomiting? Answer options. A. Encouraging ambulation to stimulate peristalsis. B. Administering antiemetics to reduce nausea. C. Preparing the patient for nasogastric tube insertion. D. Recommending a clear liquid diet to rest the bowel. Correct answer. C. Preparing the patient for nasogastric tube insertion. Rationales for each answer option. Rationale A. Encouraging ambulation. Incorrect. Ambulation is more helpful in resolving paralytic ileus than mechanical bowel obstructions. Rationale B. Administering antiemetics. Incorrect. Antiemetics relieve symptoms but do not address the underlying obstruction. Rationale C. NG tube insertion, correct. Nasogastric decompression relieves pressure and prevents further complications in bowel obstruction. Rationale D. Recommending a clear liquid diet, incorrect. Patients with complete obstruction are kept NPO to avoid worsening symptoms. Mnemonic. Block for bowel obstruction. Bowel rest, NPO. Leverage, NG decompression. Observe for signs of perforation. Correct fluid imbalances. Know the need for surgery. Central topic explanation and comparison. Bowel obstruction. A blockage preventing the normal flow of intestinal contents, categorized as mechanical, e.g. tumours, adhesions, or functional, e.g. ileus. Key interventions. Insert an NG tube for decompression. Keep the patient NPO and provide IV fluids. Monitor for complications such as perforation or ischemia. Comparison with paralytic ileus. Cause. Obstruction involves a physical blockage, while ileus is due to impaired peristalsis. Management. Ileus responds to ambulation and supportive care, while obstruction often requires NG decompression or surgery. 10. Question. A 60-year-old male with a history of cirrhosis presents with worsening ascites and respiratory distress due to abdominal pressure. Which intervention should the nurse prioritize? Answer. Options. A. Administering lactulose to prevent hepatic encephalopathy. B. Preparing the patient for abdominal paracentesis. C. Restricting fluid intake to reduce ascites. D. Monitoring for signs of variceal bleeding. Correct answer. B. Preparing the patient for abdominal paracentesis. Rationales for each answer option. Rationale A. Administering lactulose, incorrect. Lactulose is used for encephalopathy, but does not address the immediate concern of respiratory distress from ascites. Rationale B. Paracentesis, correct. Paracentesis relieves ascites, reducing abdominal pressure and improving respiratory symptoms. Rationale C. Restricting fluid intake, incorrect. Fluid restriction is helpful for hyponatremia, but does not provide immediate relief from ascites. Rationale D. Monitoring for variceal bleeding, incorrect. While important, this does not address the current issue of respiratory distress due to ascites. Mnemonic. Cirrhosis for symptom management. Correct underlying causes. Initiate paracentesis for severe ascites. Restrict sodium intake. Regularly monitor liver function. Hepatic encephalopathy management. Organize follow-up for complications. Support nutritional needs. Identify infection risks. Stable fluid balance. Central topic explanation and comparison. Liver cirrhosis and ascites. Cirrhosis causes portal hypertension, leading to fluid accumulation in the abdomen, ascites. Severe cases can impair respiration and require paracentesis. Key interventions. Perform paracentesis for symptomatic relief. Administer diuretics and enforce sodium restriction to manage ongoing fluid retention. Monitor for complications such as spontaneous bacterial peritonitis, SBP. Comparison with hepatic encephalopathy. Symptoms. Encephalopathy presents with confusion and asterixis, while ascites causes abdominal distension and respiratory issues. Management. Ascites is managed with paracentesis and diuretics, while encephalopathy. Question 11. A patient with a known history of celiac disease presents with persistent diarrhea and unintentional weight loss despite adhering to a gluten-free diet. What diagnostic test should the nurse anticipate for further evaluation? Answer options. A. Colonoscopy to rule out Crohn's disease. B. Small bowel biopsy to assess for refractory celiac disease. C. Serum antibody testing for gluten exposure. D. Stool analysis to evaluate for infectious causes. Correct answer. B. Small bowel biopsy to assess for refractory celiac disease. Rationales for each answer option. A. Colonoscopy. Incorrect. Colonoscopy is used for lower GI conditions like Crohn's disease, but does not directly evaluate the small intestine for refractory celiac disease. B. Small bowel biopsy. Correct. Persistent symptoms, despite a gluten-free diet, may indicate refractory celiac disease, which requires confirmation via biopsy. C. Serum antibody testing. Incorrect. Antibody tests identify gluten exposure, but are less useful in diagnosing refractory cases. D. Stool analysis. Incorrect. Stool analysis is more appropriate for infectious diarrhea, not celiac-related issues. Mnemonic. Celiac for persistent symptoms. Check for gluten contamination. Evaluate for deficiencies. Look for refractory disease. Initiate diagnostics. Biopsy. Assess adherence to diet. Consult specialists. Central topic, explanation and comparison. Celiac disease and refractory cases. Celiac disease is an autoimmune disorder triggered by gluten, leading to intestinal damage. Refractory celiac occurs when symptoms persist, despite a strict gluten-free diet. Key interventions. Evaluate adherence to a gluten-free diet. Perform a small bowel biopsy to confirm refractory disease. Monitor and correct nutritional deficiencies: iron, calcium, vitamin D. Comparison with non-celiac gluten. Sensitivity, pathology. Celiac involves autoimmune damage, while non-celiac gluten sensitivity does not. Symptoms. Both cause diarrhea and bloating, but celiac can lead to malabsorption and systemic issues. Management. Celiac requires lifelong gluten avoidance, while non-celiac sensitivity may have more flexible dietary options. Question 12. A patient undergoing treatment for inflammatory bowel disease, IBD, reports abdominal cramping and bloodstreak diarrhea. What is the priority nursing intervention? Answer options. A. Monitoring for signs of toxic megacolon. B. Administering anti-inflammatory medications as prescribed. C. Encouraging a low-residue diet. D. Providing stool softeners to reduce straining. Correct answer. A. Monitoring for signs of toxic megacolon. Rationales for each answer option. A. Monitoring for toxic megacolon. Correct. Toxic megacolon is a life-threatening complication of IBD that requires prompt recognition and intervention. B. Administering anti-inflammatory medications. Important but not correct. While medications help manage IBD, the immediate priority is detecting complications. C. Encouraging a low-residue diet. Incorrect. Dietary changes are helpful, but secondary to monitoring for acute complications. D. Providing stool softeners. Incorrect. Stool softeners are not a priority in managing active IBD flares or complications. Mnemonic. Megacolon for toxic megacolon signs. Monitor for fever. Evaluate abdominal distension. Guard against perforation. Assess bowel sounds. Hypoactive. Check for tachycardia. Observe for worsening pain. Look for leukocytosis. Order imaging. Notify the provider immediately. Central topic, explanation and comparison. Inflammatory bowel disease, IBD, includes Crohn's disease and ulcerative colitis, characterized by inflammation and ulceration of the GI tract. Key interventions. Monitor for complications like toxic megacolon or perforation. Administer medications to reduce inflammation and induce remission. Encourage dietary modifications to minimize symptoms. Comparison with irritable bowel syndrome, IBS. Pathology. IBD involves structural damage and inflammation, while IBS is a functional disorder. Symptoms. IBD presents with systemic signs, e.g. fever, whereas IBS does not. Management. IBD requires anti-inflammatory or immunosuppressive therapies, while IBS focuses on dietary and lifestyle changes. Question 13. A patient with a history of alcohol use disorder is admitted with severe epigastric pain radiating to the back, nausea and vomiting. Laboratory results show elevated lipase and amylase levels. Which nursing intervention is the priority? Answer. Options. A. Administering IV fluids to prevent hypovolemia. B. Encouraging oral hydration with clear liquids. C. Administering antibiotics to treat infection. D. Preparing the patient for emergency surgery. Correct answer. A. Administering IV fluids to prevent hypovolemia. Rationales for each answer option. A. Administering IV fluids, correct. Fluid resuscitation is the cornerstone of initial management in acute pancreatitis to prevent hypovolemia and maintain organ perfusion. B. Encouraging oral hydration, incorrect. Patients with acute pancreatitis are kept NPO to minimize pancreatic stimulation. C. Administering antibiotics, incorrect. Antibiotics are not routinely recommended unless there is evidence of infection, such as necrosis or abscess. D. Preparing for surgery, incorrect. Surgery is not the first-line treatment for acute pancreatitis unless there are complications like gallstone obstruction requiring intervention. Mnemonic. Pain for pancreatitis management. Pain control with analgesics. Administer IV fluids. Initiate bowel rest, NPO. Nutritional support if prolonged NPO. Central topic, explanation and comparison. Acute pancreatitis. Inflammation of the pancreas, often caused by gallstones or alcohol use. Symptoms include severe epigastric pain radiating to the back, nausea and vomiting. Key interventions. Administer IV fluids to prevent hypovolemia. Keep the patient NPO to rest the pancreas. Monitor for complications like necrosis or organ failure. Comparison with chronic pancreatitis. Symptoms. Acute presents with sudden, severe pain, while chronic involves recurrent episodes and progressive damage. Management. Chronic pancreatitis requires long-term enzyme replacement and dietary modifications. Question 14. A patient presents with dark, tarry stools, melena, and dizziness. The patient has a history of NSAID use for chronic pain. Which diagnostic test is most likely to confirm the source of bleeding? Answer: options. A. Colonoscopy. B. Upper endoscopy. EGD. C. Capsule endoscopy. D. Abdominal CT scan. Correct answer: B. Upper endoscopy, EGD. SAS. Rationales for each answer option. A. Colonoscopy, incorrect. While colonoscopy evaluates lower GI bleeding, melena typically originates from the upper GI tract. B. Upper endoscopy, correct. EGD is the gold standard for diagnosing upper GI bleeding, such as that caused by NSAID-induced ulcers. C. Capsule endoscopy, incorrect. This is used for obscure GI bleeding, typically in the small intestine, not for initial evaluation of melena. D. Abdominal CT scan, incorrect. CT imaging is not the primary diagnostic tool for active GI bleeding. Mnemonic. Melena for upper GI bleeding workup. Monitor vitals. Evaluate for shock. Look for source via EGD. Ensure IV access. NPO status. Anticipate blood transfusion if needed. Central topic, explanation and comparison. Upper GI bleeding, often caused by peptic ulcers, esophageal varices, or NSAID use. Symptoms include melena, hematemesis, and dizziness. Key interventions. Perform an EGD to locate and treat the bleeding source. Stabilize the patient with IV fluids and blood products if needed. Administer PPIs to reduce acid secretion and promote healing. Comparison with lower GI bleeding. Symptoms. Upper GI bleeding causes melena, while lower GI bleeding often presents with hematochezia, bright red blood. Diagnosis. Upper GI bleeding is evaluated with EGD, while lower GI bleeding often requires colonoscopy. Question 15. Which intervention is most appropriate for a patient with liver cirrhosis experiencing significant ascites and difficulty breathing? Answer: options. A. Restricting sodium and fluid intake. B. Preparing the patient for paracentesis. C. Administering albumin to improve oncotic pressure. D. Positioning the patient in a high Fowler's position. Correct answer: B. Preparing the patient for paracentesis. Rationales for each answer option. A. Restricting sodium and fluids, important but not correct. Sodium and fluid restrictions help manage ascites long term, but do not address acute respiratory distress. B. Preparing for paracentesis. Correct. Paracentesis removes excess fluid, providing immediate relief from respiratory distress caused by severe ascites. C. Administering albumin. Important but not correct. Albumin infusion supports oncotic pressure but does not provide immediate symptomatic relief. D. Positioning in high Fowler's, supportive but not sufficient. While it can ease breathing temporarily, it does not address the underlying cause of respiratory distress. Mnemonic. Ascites for management. Albumin administration. Sodium restriction. Consider paracentesis for severe cases. Initiate diuretics. Treat underlying liver disease. Evaluate for complications. SBP. Support respiratory function. Central topic. Explanation and comparison. Liver cirrhosis and ascites. Cirrhosis causes portal hypertension, leading to fluid accumulation in the peritoneal cavity. Severe ascites can impair breathing and mobility. Key interventions. Perform paracentesis to relieve symptoms of severe ascites. Restrict sodium intake and administer diuretics for ongoing management. Monitor for complications like spontaneous bacterial peritonitis, SBP. Comparison with hepatic encephalopathy. Symptoms. Ascites causes abdominal distension and respiratory distress, while encephalopathy presents with confusion and asterixis. Management. Ascites requires fluid management, while encephalopathy is treated with lactulose and rifaximin. Question 16. A patient presents with acute abdominal pain, fever, and rebound tenderness. Imaging confirms a ruptured appendix. What is the nurse's priority intervention? Answer. Options. A. Administering IV antibiotics to prevent sepsis. B. Preparing the patient for emergency surgery. C. Keeping the patient NPO and starting IV fluids. D. Monitoring for signs of peritonitis. Correct answer. B. Preparing the patient for emergency surgery. Rationales for each answer option. A. Administering IV antibiotics. Important but not correct. Antibiotics are necessary but are an adjunct to surgical management. B. Preparing for surgery. Correct. A ruptured appendix is a surgical emergency requiring immediate intervention to prevent widespread infection. C. Keeping NPO and starting IV fluids. Important but not correct. These measures support stabilization but do not resolve the source of infection. D. Monitoring for peritonitis. Important but not correct. Monitoring is essential, but the definitive treatment is surgery. Mnemonic. Append for acute appendicitis management. Assess for rebound tenderness. Prepare for surgery if rupture occurs. Provide IV fluids. Ensure NPO status. Notify surgeon promptly. Deliver antibiotics preoperatively. Central topic, explanation and comparison. Acute appendicitis. Inflammation of the appendix that can lead to rupture if untreated, causing peritonitis and sepsis. Key interventions. Prepare for surgical removal, appendectomy. Administer IV fluids and antibiotics to stabilize the patient. Monitor for complications like abscess or peritonitis. Comparison with diverticulitis. Location. Appendicitis involves the appendix, while diverticulitis typically affects the sigmoid colon. Symptoms. Both can cause abdominal pain and fever, but appendicitis pain is localized to the right lower quadrant. Management. Appendicitis requires surgery, while diverticulitis is often managed with antibiotics and bowel rest. Question. A patient presents with severe abdominal cramping, diarrhea, and a high-pitched bowel sound upon auscultation. Imaging confirms a small bowel obstruction. What is the nurse's priority action? Answer options. A. Administering antiemetics to control nausea. B. Preparing the patient for nasogastric tube insertion. C. Encouraging ambulation to relieve obstruction. D. Providing clear liquids to promote bowel rest. Correct answer. B. Preparing the patient for nasogastric tube insertion. Rationales for each answer option. A. Administering antiemetics. Incorrect. Antiemetics alleviate nausea, but do not address the underlying obstruction. B. Preparing for NG tube insertion. Correct. Nasogastric decompression relieves abdominal pressure and prevents further complications in small bowel obstruction. C. Encouraging ambulation. Incorrect. Ambulation is helpful for ileus, but is not appropriate for a mechanical bowel obstruction. D. Providing clear liquids. Incorrect. Patients with a bowel obstruction are kept NPO to prevent further complications. Mnemonic. Obstruct for small bowel obstruction management. Observe for worsening symptoms. Bowel rest, NPO. Support with IV fluids. Treat with NG decompression. Reassess bowel function. Understand surgical indications. Consult provider. Track vital signs and Baitishi. Central topic explanation and comparison. Small bowel obstruction. A blockage in the small intestine, often due to adhesions, hernias, or tumours. Symptoms include cramping, vomiting, and abdominal distension. Key interventions. Insert an NG tube for decompression. Keep the patient NPO and provide IV fluids. Monitor for signs of perforation or ischemia. Comparison with large bowel obstruction. Symptoms. Large bowel obstruction causes distension and less vomiting compared to small bowel obstruction. Management. Both require NG decompression, but large bowel obstruction may more frequently require surgical intervention. Question 18. A patient with suspected acute peritonitis presents with abdominal rigidity, severe pain, and fever. What is the nurse's priority action? Answer. Options. A. Administering antibiotics to control infection. B. Preparing the patient for surgical intervention. C. Placing the patient in a semi-Fowler's position. D. Providing IV fluids to prevent dehydration. Correct answer. B. Preparing the patient for surgical intervention. Rationales for each answer option. A. Administering antibiotics. Important, but not correct. Antibiotics are necessary, but are an adjunct to surgical management of peritonitis. B. Preparing for surgery. Correct. Peritonitis is a surgical emergency requiring immediate intervention to control the source of infection. C. Placing the patient in semi-Fowler's. Supportive but not sufficient. This position can ease breathing but does not address the underlying infection. D. Providing IV fluids. Important but not correct. IV fluids help stabilize the patient, but do not resolve the source of peritonitis. Mnemonic. Pain for peritonitis management. Prepare for surgery. Administer antibiotics. IV fluids for stabilization. Notify provider promptly. Central topic explanation and comparison. Acute peritonitis. Inflammation of the peritoneum, often caused by rupture of an abdominal organ or infection. Symptoms include abdominal rigidity, severe pain, and fever. Key interventions. Administer IV antibiotics to control infection. Prepare for surgery to address the underlying cause. Monitor for signs of septic shock. Comparison with sepsis. Origin. Peritonitis is localized to the peritoneum but can progress to sepsis if untreated. Management. Both require antibiotics, but peritonitis often necessitates surgery. Question 19. A patient with suspected colorectal cancer reports a change in bowel habits and unintentional weight loss. What diagnostic test should the nurse anticipate? Answer. Options. A. Upper endoscopy. B. Colonoscopy with biopsy. C. CT scan of the abdomen. D. Fecal occult blood test, FOBT. Correct answer. B. Colonoscopy with biopsy. Rationales for each answer option. A. Upper endoscopy, incorrect. Upper endoscopy evaluates the esophagus, stomach, and duodenum, not the colon. B. Colonoscopy with biopsy, correct. This is the gold standard for diagnosing colorectal cancer by directly visualizing and sampling suspicious lesions. C. CT scan, important but not primary. CT imaging helps stage colorectal cancer, but does not confirm the diagnosis. D. FOBT, screening tool. FOBT detects occult blood, but is not diagnostic for cancer. Mnemonic. Cancer for colorectal cancer workup. Consider risk factors, age, family history. Anticipate colonoscopy. Note symptoms: weight loss, bowel changes. Check for metastasis with imaging. Educate about treatment options. Refer for oncology follow-up. Central topic explanation and comparison. Colorectal cancer, a malignancy in the colon or rectum, often presenting with changes in bowel habits, bleeding, and weight loss. Early detection improves prognosis. Key interventions. Perform colonoscopy with biopsy to confirm diagnosis. Stage the disease with imaging, CT, MRI. Collaborate with oncology for treatment planning. Comparison with diverticulosis. Symptoms. Diverticulosis is typically asymptomatic, while colorectal cancer presents with systemic signs like weight loss. Diagnosis. Diverticulosis is identified via imaging, while cancer requires biopsy. Question 20. A patient with a history of ulcerative colitis presents with profuse diarrhea, tachycardia, and abdominal distension. The nurse suspects toxic megacolon. What is the immediate priority? Answer. Options. A. Administering corticosteroids to reduce inflammation. B. Preparing the patient for emergency colectomy. C. Placing the patient on bowel rest with IV fluids. D. Administering antibiotics to prevent infection. Correct answer. B. Preparing the patient for emergency colectomy. So, rationales for each answer option. A. Administering corticosteroids. Important but not correct. Corticosteroids reduce inflammation, but are not sufficient in cases of perforation or severe toxic megacolon. B. Preparing for colectomy. Correct. Toxic megacolon is a life-threatening condition requiring immediate surgical intervention. C. Bowel, rest and IV fluids, supportive but not sufficient. These stabilize the patient, but do not resolve the life-threatening complication. D. Administering antibiotics, important but not correct. Antibiotics prevent sepsis but are adjunctive to surgery. Mnemonic. Megacolon for management. Monitor vitals. Evaluate abdominal distension. Guard against perforation. Assess for shock. Consult surgical team. Organize preoperative care. Limit oral intake, NPO. Order imaging. Notify provider promptly. Central topic, explanation and comparison. Toxic megacolon. a severe complication of ulcerative colitis characterized by rapid colon dilation, systemic toxicity, and high risk of perforation. Key interventions. Prepare for emergency colectomy to prevent perforation and sepsis. Administer corticosteroids and antibiotics as supportive measures. Monitor for hemodynamic instability and provide IV fluids. Comparison with Crohn's disease. Complications. Toxic megacolon is more common in ulcerative colitis than Crohn's disease. Management. Both may require surgery, but toxic megacolon. Thank you for tuning in to Clinic RN, your ultimate Nclex prep partner. Don't forget to like, subscribe, and hit the notification bell so you never miss a tip, trick, or practice question. Have questions or suggestions for future videos? Drop them in the comments. We'd love to hear from you. Keep pushing forward, future nurse. You've got this, and Clinic RN is here to guide you every step of the way. See you in the next video.